Hey, everybody. Welcome to First Bite. I'm Michelle Dawson. So, this week, I'm actually not on this episode. I have the joy of highlighting a conversation that Erin Forward has with an invited guest, a woman that she knows from the Floortime feeding world, Miss Amy Zembrisky. Amy, I'm hoping I said your name right. If I didn't, I take full responsibility. But in this episode, Amy and Erin have a conversation all about how do I get started with neurodiversity affirming feeding therapy. And and y'all, just saying those words together has more weight after coming back from the Feeding Matters conference, especially given the significant amount of emphasis that the convention chairs, Dr. Amy Delaney and Dr. Rocky Garcia, placed this year on growing the psychosocial offerings for the online course. So, big picture, if you didn't make it to Feeding Matters in Phoenix, that's okay. The conference is online. You can register now to see the bulk of the courses that were recorded between now and I think April 1st is the day that they close. So, one, if you're into pediatric feeding disorder, sign up for the Feeding Matters conference. Two, this conversation that Amy and Erin has is a great starting point on intervention, on how do we create a safe space, and they even go through case studies so that the child feels that they are in a safe and welcoming space to grow. For those of you that are interested in getting more into feeding, when we go to chart according to the 4 domains, medical, psychosocial, nutrition, and feeding skill, those first several evaluations can feel very overwhelming because how do we chart to document according to the 4 domains without engaging in scope of practice encroachment into the other practitioners' area? And psychosocial can is the purview of psychologists, but also that's where we as speech language pathologists engage in the counseling portion of her scope of practice. So just kind of bear that as in mind that this today's conversation that you're about to listen to with Amy and Erin from that rehab clinical what do I do perspective fits nicely within that psychosocial domain while maintaining within our scope of practice. And if you want to learn more about the psychosocial domain, that puts you back at getting into the Feeding Matters conference that's going on live right now. Well, live in the on demand sense. But y'all, there's so many resources out there and there's so many opportunities to be built up to grow your skill set. You have to be willing to take that leap of faith. So for leaping with Erin and I, and today with Amy, I just want to say thank you. Um, it's been a great week, and I hope that you're having a great kickoff to March. May yours also include heavy duty antibiotics, if indicated. And I can say that on a personal note, this mommy got put on augmentin and prednisone. I'm looking because a tiny human over here on the left is also down with a sinus infection. And I may or may not have lost my mind on Saturday, courtesy of prednisone. So yeah, that happened. But you know what? He's giving me the thumbs up. All of the bathrooms in our house are pretty much spotless, and every floor is mopped, and the house looks great. So I hope your March is off to a great start, with or without augmentin and prednisone in the taper dose. I wish y'all could see Bear's face, who also has a sinus infection unrelated to his mother's, but cootie life, that's where we're at. But y'all have a great week. Enjoy today's conversation and stay tuned. We're taking, Erin and I are taking a break. We're taking the month of April off. We're coming back big and strong for May for pediatric feeding disorder and ARFID Awareness Month. because the 2 months are now combined. But so we hope you enjoy the month of March while we work on some rebranding during April, maybe some new pictures, which is kind of cool because I don't know if y'all can tell, but my curls came back today. Yay for new conditioner. But yeah, y'all have a great one and enjoy the episode. Bye.
Perfect. Hello, everybody. Welcome to another episode of First Bite. You have me, Erin, and I'm so excited to have not only someone who I'm lucky enough to call a friend, and regularly she's someone I call and problem solve and has mentored me in a lot of ways. But we have Amy Zembrisky here. I think I already said your name, but that's all right. Who is amazing in the context of a lot of things. Um, I've talked about her before on the podcast with her Neurodiversity Affirming Goal Bank. She does a lot of work in the space of AAC and GLP. But what I really love about Amy is that she never puts kids into a box and she thinks really holistically. And she is someone that I think really focuses on the child and who they are and helping with their authentic growth. And so today we wanted to talk a lot about feeding and the scary parts of what do I do when I've been working on communication? How do I introduce feeding? Like, how do I take that jump? How do I transition? Because that can be really overwhelming. And sometimes it feels like you have to take this huge jump. But sometimes it's also these small steps. And then also talking about looking at that child holistically, we have to consider a lot of things, which might include AAC, which might include play, which might include Gestalt language processing. And so I will let Amy introduce herself before we fully get into it, but I'm so happy to have you here.
Thank you so much for having me, Erin. I am so excited. So I am a speech therapist and I've been practicing for, I think, oh my goodness, 8 years, although I did take 1 year off. I started off working in acute care. I worked in some skilled nursing facilities per diem. I pretty much dabbled in almost every setting that you probably could as an SLP. And then I actually work for myself. I have my own private practice that has been running for, I believe, 2 years now, and I've been supporting primarily autistic children. And so I do work with a lot of AAC users, a lot of Gestalt language processors, but I also work with some, late talkers and some articulation. So I am just so excited to be here. Feeding therapy is something that I used to find really daunting and I didn't particularly enjoy because I saw that so many of my clients did not like what I was doing. I also didn't like what I was doing, but I just didn't really know how to approach it. And so I am just so grateful to have connected with Erin because she has also been a mentor to me. And a lot of the things that she's taught me and the things that I've learned in her course just have been so instrumental in the success that I've had in some of my clients. And I now feel just so much more comfortable with incorporating feeding therapy into a service that I can offer for my clients. So thank you for having me.
Yeah, I think that when I was starting to, because I originally only wanted to work with medically complex kids. I don't know why, but that was where I was focused on. And then when I started working at a private practice and saw a lot more autistic kids, I was like, oh, these children need feeding support. But the feeding support that I had learned about, I mean, I will admit, I used sticker charts, I used compliance-based strategies because I didn't know what to do. But every time I was doing it, it just didn't feel good. And I knew they didn't like it, but I would have the caregiver, understandably so, wanting progress. And I didn't know how to make progress. And I think as a really young clinician too, it's hard to feel confident enough to step outside the box of what you're being taught. And so then if you don't have another way or you don't have a mentor that's guiding you in that direction, it can be really, really daunting. And so unfortunately, I think for a lot of clinicians, feeding just became something, like you said, that they didn't want to do because they, it can seem really overwhelming. I love feeding therapy, but I do think that a lot of feeding therapists have this habit of like making it seem almost unattainable, and it's not. Um, but then I have so many feeding therapists that I work with that don't want to see autistic kids, unfortunately. I say, like, I was a therapist that was like, no, I only want medically complex kids, and then I really fell in love with autistic kids. Um, but there can be really, really subtle changes that you make just to start building a relationship with food. And there's a lot of clinicians out there that are already connecting with autistic kids and are already providing really amazing relationship-based therapy that honestly, I think it's a little bit easier for them to dip their toe into feeding with this child than this child to go to a completely new feeding therapist. And I think you and the success that you've had is an amazing example of that, which we're going to talk about a couple of cases today, because I know that can be really helpful. Because again, I get this question a lot of like, what is your therapeutic strategy or what's your intervention? And my answer is always the intervention is in how you're assessing a child, how you're working with a child. It's so individualized. I don't really have an answer for that, but I can tell you all the ways and the tools in my toolbox and the things I add to my lens to be able to support that child with feeding. And so we talked a little about like where we want to start today because we have so much that we can talk about. I mean, Amy and I talk pretty regularly in general. We leave very long voice memos, which I thoroughly enjoy. Um, but I think maybe let's start today a little bit about like your journey of starting feeding therapy. We can either start with a case specifically and then kind of branch out from there, or talk about like how you initially started to introduce even the idea of, because I do think what happens too is we work with, and I'm guilty of this too, like you work with a child for maybe even a couple of years, and then all of a sudden the caregiver says, well, feeding's always been hard. And you're like, oh, well, or I've had caregivers say to me, like, feeding's always been hard, but we didn't think anybody could help us. And so now you've been working with this child for a while and you're like, I really want to help their feeding, but like, what do I do? How do I shift that therapy session? How do I have that conversation with a caregiver? Where does that even start?
Yeah. So that's such a good question. And what I love what you said earlier is just really how important it is to try to minimize the number of providers that a child has to have an interaction with. And I never really honestly thought about it that way until just a couple months ago, where I, so I work with a lot of autistic kids, and a lot of my clients are very, selective in their eating. And some parents are like, you know what, it's okay. I'm just, honoring what they want. And then some parents feel frustrated, but they don't know where to go. And so I've actually referred their children out and, saying, oh, you could try to work with this provider, and I'm happy to collaborate. And it wasn't until I started really, again, taking your course of how much of an additional cognitive load that is for the parents and for the child, and just having the child have to build a relationship all over again with somebody else. It's a lot to ask of them. And
Mm-hmm.
like, now we're now sending you to another appointment. What is their schedule going to look like? And so thinking about how feeding therapy is just like another thing for them to do. And so I really loved how you framed it in saying, feeding therapy can be done with you if you're already working with the child. It's just knowing, how can I work with them now? Obviously, like if there's, a medically fragile child or something like that, I don't feel comfortable and I'm going to refer out. But in terms of, selective eaters, and ruling out any other kind of medical diagnoses, I that's something I wanted to do, but nothing I did before was helpful. A lot of my first feeding therapy sessions were very much, you're going to sit at this table, you're going to sit in the chair, and we're going to go through, we're going to just look at it, we're going to touch it, we're going to smell it, we're going to lick it, we're going to take a little bite, we can chew it and then spit it out. Like, it just didn't feel natural for me. But that's really kind of how I was taught. And I didn't know what to do. Right. And so having moved away from that, it's been just a nice breath of fresh air after having been mentored by you and learning more, because now when I have clients who are coming in to see me, um, that actually is a question I ask now during the evaluation process. How do you feel about mealtime? How do you feel about feeding? And if I can't necessarily fit a feeding evaluation with the language evaluation, I at least know that it's something I can address moving forward. Because sometimes, I want therapists to know, and I don't know if you agree, Erin, I feel like you probably do, but sometimes I do get a family who comes in to see me and they're like, well, their language is the priority, but I do want to work on their feeding. And like, language is feeding, feeding is language. And so I tell
Mhm.
families, why don't we do our language assessment? And because they don't trust me yet, because I'm such a new person, sometimes I say, like, why don't we do feeding once we start to build that relationship, so they don't feel so overwhelmed of, what does this woman want from me? Like, what is she,
Mhm.
like, what is she doing? Right? Because kids are smart and they can detect, like, okay, I'm here for some reason and I don't want to feel this pressure from her. So sometimes I have families who are like, I brought this food just in case. And sometimes all I'll do is like leave a preferred snack out during the
Mhm.
evaluation. And I'll say, okay, Johnny, like, your popcorn and your water are here. And like, if you want it, we can, you can grab it at any point. So that might honestly be where I start in my evaluation, so that they know. And it is very cool to watch them, like, they'll look at it and they'll touch it and be like, I don't really want this. And then maybe 30 minutes later, after they feel safe,
Mhm.
I see them going to sneak off for their snack, and then they give me their snack to help me open it. And that might be just where I start. And even for therapy, I explained to parents, and something that you taught me is, just because a preferred food is something they like, it doesn't mean that it's going to be safe in a new environment. So now I'm teaching them that they're in my office in this new space, and it's a safe place where I haven't done anything to your preferred snack. I'm not tricking you. I'm not adding something in there. Like, it's going to be the same thing whether you're here or at home. And so I've honestly started a lot of my therapy in that way. Let's just show you that this is a safe space for you to snack on your favorite thing in the world and drink your water or whatever it is.
Mhm.
And that's been really, really helpful when I start to maybe add new foods or showing them different kinds of things. But that's something that I felt so happy in hearing from you. And I've found it to be so, so successful. So successful.
Yeah. Yeah. And I mean, even from like being a trauma-informed therapist too, like having snacks and water available can also support a lot of those behaviors, because we need to be fed and we need to be hydrated to be able to think. And so you're already, not only are you teaching this child that like this is a safe environment for you to eat the food that you like, but you're also providing, as TBRI, trust-based relational intervention, would talk about, like the environmental factors, like these ecological factors that you're providing to help support them being able to just stay regulated and engaged and work with you. And so, and what I will say, I do think it's important, and like Amy acknowledged, making sure that you do have a basic understanding of like typical feeding development and what, oral motor skills are necessary. And you talk to family about like, do they have an oral pharyngeal dysphagia, so that you're aware of something like that, if they have any oral concerns, or if they aspirate, things like that. Like, what are these questions I need to ask to make sure I have this foundation understanding? Because if I don't have any understanding of that, then, I want to make sure that they're safe physically eating the food. But kids are eating at home, like kids are eating everywhere. So to say, no, I'm not, I can't work on this at all, but like they're doing it everywhere else, that is really important to bring it in. And that's a huge social factor. And I fully agree. And I think where we get in trouble sometimes with feeding therapists is if you're not working on communication, you feel like you're stuck. Like, I have to get some progress. I have to have them, I used to be, feel like I had to get them to take a bite of something. And I recognize there's so many other factors to mealtime, but also I try to work on communication with them as well, because social emotional development does lead most of the time to more comfort with feeding, because I can communicate what I want. I can tell you if I don't like something. I have trust in you. I can problem solve. I have the confidence to know that if I don't like a food, I can work with you to tell you that I don't like it and why I don't like it, and maybe compromise and ask for something else. Or if I don't have any of those skills yet, I feel really helpless, and that's going to cause more anxiety around food. So I work with a lot of kids where I've said, we're going to build relationship first. We're going to, work in the context of play. I'm going to learn about your child. I'm going to learn what they like. I'm going to learn what makes them feel safe. And then I'm going to bring feeding in, because feeding is really, really intimate, and feeding involves putting something in our bodies, whether it's through our mouth or through a feeding tube or whatever that is. And that can be really scary. And feeding can have a lot of trauma. And so we have to be really cognizant of that. And relationship is the best way to support that.
Yeah. And I love that because I never really thought about feeding therapy as being so intimate. And once I've started to really think about the importance of relationship, importance of mealtime literacy that you talk about all the time, like, how do I like to learn about food? What makes me feel safe during mealtime? Like, these are not things that I used to think about. And so I'm thinking about a client that I used to work with, and I think at the time he was 3 or 4. And we were primarily just doing language therapy. And I can't remember how the picky eating mom mentioned came up, but it was something that came up. And it happened to be a line at the time when I was taking your course. And I was like, okay, why don't we try to start working on this together? And it was so interesting because when I said, one of the things I said to mom, okay, why don't you bring some foods that he doesn't like, foods that he does like? And me thinking that, okay, he has a relationship with me, and I like presented him with all these things, and it was just too much. It was too
Mm-hmm.
much. And I could see he was so overwhelmed, and I was overwhelmed. And I was like, okay, this was too much, too fast, right? I think we forget that it's a lot. And I was thinking about it after he left. I was like, oh my goodness, we had these, I can't even remember now, these 3 non-preferred foods that he didn't like, and then preferred foods that he liked, but he didn't feel safe with anything. He didn't want to try
Mm-hmm.
his preferred foods. He didn't want to eat those. And so after he left that day, I reached out to mom and I said, you know what? I think this was too much too fast. And I would like for us to maybe just try to build that safety in our therapy sessions first. Bring in a preferred snack. And I remember it was a muffin. She's like, he loves these muffins. And I said, okay. And I made sure that he knew the muffin was available there. And something else that I started doing, Erin, I start to just snack on some things in my sessions with them. Like, if I have my own
Mm-hmm.
snack, so that they can see, like, oh, Miss Amy's eating in here, so I can eat. So I think I was eating, like, I don't know, popcorn or something. And he was just watching, and he was like looking at his muffin, and he kind of kept going back and forth. And I remember this so vividly. We were playing with this car ramp, and I had the muffin just next to the car ramp. And he started to just like pick at the muffin, and he started to eat it. And I could tell in that moment he felt safe enough to do that, because he was so hesitant to even interact with something mom knows he loves. But as soon as that pressure was taken off, as soon as I, didn't say, oh, we have these things you don't like, do you want to try this? Like,
Mm-hmm.
all that pressure was taken off, and he felt that autonomy to decide whether or not he wanted to eat that muffin, and he did. And he really, really loved that. And it was so interesting because week after week, he would just know the muffin was in there, and he would just grab it and start eating it. And one time he was running out of the office, and he came back for his half muffin that he left, and he wanted to make sure he finished it and like ate it. So I thought that was so, like, just so great. And people listening might be like, well, how is that going to make any progress, right? And
Mm-hmm.
so a lot of it, like you say too, is caregiver education. And so I shared with mom, this is what I'm doing in therapy, and just some minor things that you could be doing at home is truly removing that pressure. We don't have to ask him if he wants to take a bite. We don't have to ask him if he wants to smell it or touch it or anything of that nature. We can just involve him to the, like, in mealtime in the way that he feels safe, whether that's being a part of the cooking process but not pressuring him to eat it, right? So many of my kids like love to be a part of cooking, and so I tell her, like,
Mm-hmm.
you know have him pour the pasta in the water, or have him, mix up the sauce in whatever it is. But we don't even need to comment on, do you want to try this? Or do you want to do this? Like, you can model these behaviors for them, and they can decide if they want to like follow suit. Like, he would watch me, sniff a food myself, because I do like to smell foods before I try them, because I don't like strong smells. So like,
Mm-hmm.
but then he would kind of do that himself, but I'm not saying, oh, do you want to smell this or do you want to bite it? He gets
Right.
to decide. And I think that's the most important thing that I learned. I mean, there's so many things I feel like I learned from you, Erin, but the autonomy piece is 100% like the most important thing. When kids feel like they can say no, that they can advocate for themselves at any point during mealtime, and that their request is going to be honored, I find that so many of my clients are just so much more receptive.
Yeah. Okay, I have so many thoughts and I'm trying to think of which I want to cut because I love all of that so much. And this is why I love you, Amy, because like you'd say something, I'd be like, and this part too, and you're like, oh yeah, and this part too. Because from explaining to caregivers, like that's also building attachment. Like I'm doing this with your child because of this. And now you understanding this allows you to better relate to your child and build a stronger attachment, which is a huge part of mealtime. I often say, like, this doesn't working on with mealtime, building attachment at mealtime doesn't necessarily mean that you're going to have this picture perfect. I'm sitting at the table with you. We're bonding. We're having a great time. We're having joy. We're eating the same food. What it means is I, as a caregiver, or, whoever's a caregiver is going to be able to read my child's cues and better attune to them so that I can support what they need in that moment. And so that's also what you're building by like explaining to that caregiver. And how often in this world, like, is this child not understood? And so finding more spaces where this child can feel understood and feel safe and advocate for themselves does set them up for success. We don't have to prepare these kids for the real world. Like, that's a mindset we have to shift from, because the more we can help them understand themselves, why they do what they do, help the caregiver understand them, then they can advocate for what they need. And I love what you talked about too, with like offering these opportunities and allowing them to decide. Where I think caregivers and clinicians get lost sometimes is like, how do I offer? And, because all caregivers reach out and say, well, this therapist told me I have to give them non-preferred foods on their plate. I've done it 15 times. They haven't had any interest. They don't want to do it because it's not meaningful to them. So, like you said, does this child like to engage in certain sensory play? Do they really like water? You're talking about putting the pasta in the water. They like water. That's so cool to watch the pasta in the water, to watch the water bubble up, to see what happens to the pasta afterwards. So you're building off of their interest to have a meaningful experience within the context of food. Amy, like, mentioned, I talk about mealtime literacy, which essentially is just like, what's their pathway to learning about food? Like, what do they even know about food? What's even their understanding? And you eating with that child helps them understand, oh, Miss Amy eats this food. In feeding therapy, I watch so many feeding therapists just sit there and stare at a kid while they're eating. It's so weird. It's weird. I get during COVID, we had to have a mat, but it's so weird. Eat with the child, like eat with them. That's how they learn. This is relationship. And we'll get into a little bit of AAC, but we talk so much in AAC about hand over hand and not using hand over hand and not forcing a kid to engage with a device, right? We model language. We may use their device. We have to think about that in the context of feeding too. Telling them take a bite, telling them exactly what to do is kind of the equivalent of hand over hand, because you're trying to fully guide them into how they're supposed to be eating. Offer them something, provide them an opportunity, and let them decide if they want to use that. I know Nicole Casey talks about like she talks about like the offer method, like similarly. And Marsha Dunn Klein, from a feeding perspective, talks about like providing opportunities. They decide if they want to take them. But what us as therapists can really help caregivers figure out is what is the most meaningful opportunity. Like what is meaningful to them, and help caregivers wash away all of the weight of the world around them that says that they have to do it a certain way. Like, it's okay if your kid just genuinely likes watching the bubbles of the pasta sauce, of the pasta bowl, putting the pasta in there, maybe mixing it up, and then they sit at the table and eat their safe food. They had an amazing, meaningful experience, and they may not need to touch it, sniff it, lick it before they take a bite. A lot of kids, like, their meaningful experience and what helps them tell them that food is safe is very different than ours. And that's that mealtime literacy piece. Like, what some kids will just watch a character on TV eat a food and then they want to eat it because now I trust it because this character ate it. So they didn't have to go through all of that. Some do, but it's helping learn about that child, and that does take time.
Yeah, and I love that you said that, Erin. And I know this is like not a case study and it's my own daughter, but Erin has been so helpful with my daughter. My daughter is 1, but just going back to something so simple like the characters on TV. My daughter loves Barney, and I was an emotional wreck as a parent because when she was teething, she just didn't want to eat anything, and I just felt so defeated. But interestingly enough, we had a birthday party for her and we bought cake pops and we put Barney's face on some of the cake pops, and she had no idea what it was, but because Barney's face was on it, she wanted to eat it. But if I offered her a cake pop that didn't have his face on it, she told me no. So like that safety and that trust with food happens at such a young age too. Like I think people forget that, especially myself, when I get clients who are 5, 6, 7, 12, like we also have to understand that some of these kids have had years and years of, maybe quote unquote bad feeding therapy or just feeling unsafe with food. And we have to really take that into consideration when we're doing feeding therapy too. Like, what is it that you're making me do? And so I don't know. I love that you said that though, because my daughter, like I said, she's only 1 and she can already tell me, and I can see in her, like the way that she's communicating with me when she feels safe with food and when she doesn't.
Yeah. And even just acknowledging that, right? Like, that's also what's so tricky for caregivers of autistic kids sometimes, is that their cues can be really hard to read. Like that double empathy problem we talk about. Like, it's not the caregiver's fault, but their cues can be really hard to read because oftentimes they struggle with interoception. So I don't even know why or what I'm feeling. Like, and then take a child who has an allergy or something going on with their esophagus, or and difficulties of regulation. So I just know I feel dysregulated or I feel uncomfortable, but I don't even know why. And that can be really, really hard for caregivers. So the more we can work with them to provide A, support, but B, also just reading their child's cues and acknowledging them can help both of them feel safe. And, this will come out later, but we're recording it around the holiday time. And that's a really challenging time because everything is changing. And the praxis of that. So you talked about that child with the muffin who knew what was going to happen. It was kind of a routine, but that routine is also praxis. I know the motor plan, I know what's going to happen, and I don't have to use as much of my brain to prepare for that. And so a lot of what I also encourage caregivers to work through is like some sort of a routine, but it doesn't have to be like always what we think about in mealtime routines. Like, the part of the routine could be you get to decide where you want to eat today. Part of the routine could be we give you choices. Like, part of the routine could be we work off of this play schema that you're using. So we have to think outside of the box, but the more that provides a lot of safety for a child when they know what's going to happen. But we have to leave room for that flexibility because it can change day to day. And you knew that your child was teething, so you had something tangible. And even with that tangible, I know my child's teething, it's still incredibly stressful because you're like, well, she's not wanting to eat all the things she wants to eat. Like, what's happening? Is she going to go back to these foods after she's done teething? And so for a lot of caregivers, it's also helping them build trust in their child and trust in themselves because everybody else is telling them not to. everybody else is saying, I see all the things on social media, like you need to do this and your child's not eating this because you're not giving them chicken sausage and vegetables and whatever. And so creating a safe space for that caregiver too, of like, I'm on your team. This is why we're doing this. Let's trust each other. Let's block out the noise. And this is going to be what's best, figuring out what's going to be best for you and your child and not worry about everybody else, which is really, really hard. But
Yeah.
like, that's what we know to be the most supportive for a child.
Yeah, and I love that you said that because it is really hard. And, if there are any caregivers who are listening too, I think one of the most validating things that, I mean, Erin says a lot of things that are really validating, but some of like the most validating thing that I always just need to be reminded of is, as long as your child is getting the nutrients that they need, like it's gonna be okay. And especially as a therapist and a parent, I definitely get trapped in like maybe over therapizing or like overthinking because I would just want to make sure that my daughter is kind of in that place where she, quote unquote should be. But, when I was freaking out about her teething, I had reached out to Erin and she said, just, it's okay. You're doing everything that you're supposed to be doing. And it's okay if Emma just is eating her safe foods. And I think maybe for a week, she just wanted like those puree pouches and yogurt and like maybe a little bit of other things. And I just felt so anxious about it. But I really leaned into that and I was like, you know what? She's okay. She's telling me clearly what she wants to eat. And I'm going to honor that for her. I'm not going to feel bad about it. And I think you're right. It's just really hard on social media too, because I even see people, making comments like, don't spoil your children, or, they need to eat what's
Mhm.
on the table. You need to like, it's just so much of
Right.
like not validating behavior for you as the
Hmm.
parent and for your child. And so I appreciate Erin for that because I don't think that caregivers are reminded of that enough, and that it's okay if your child is not eating vegetables or fruits every single meal. It's okay if you're eating like prepackaged foods. Like there's so much out there that I feel that caregivers get judged on with their feeding, and it's
Yeah.
okay. Every time I go to the store, I know my daughter wants to eat, and it doesn't matter what I'm giving her because she's gonna be fine. Partly because I also need her to not scream in the store, but I'm
Yeah.
not feeling guilty about, oh, you know what, I'm gonna give her this piece of chocolate because she wants it. Like, and that's okay. She's happy. And, you know, anyways.
Right. And kids aren't like just being bad. Like, and also the thing that I think caregivers and clinicians don't even realize too is like if a child is asking for something or they really want that sweet, if we continue to um keep that away, it builds the emotion behind it and also makes it even more like making it even more unattainable, also puts it on this like pedestal as well. Like, so if you're just like, oh, sure, I mean, you can have chocolate today and not bring too much emotion into it, then it doesn't leave it with this like, oh, this is something I have to earn. This is something that like I can't have. And now I'm going to hyper fixate on it because you just told me I can't have it. Some registered dietitians will recommend like put the dessert on the plate because now it's not, I had to earn my dessert. Now this is just a part of my meal. And it doesn't give it this like, it's better than something else, which I think is really helpful too. And and again, feeding therapy is really, really hard. Um, but you have to be comfortable with not knowing. And really, when you work with autistic kids, you have to be comfortable with like throwing out what mealtime might look like. What you have to do is go in very open and watching, just learn. And I try to tell caregivers, like, what does mealtime or what does it look like when your child is being nourished? Like, what does that look like? And go in fully. And you might even have to say, I want you to know that, and they might not believe you at first, and that's okay. I have no judgment with what your mealtime looks like. I have no concept of like what it has to look like. I want to know like what is the scenario where your child is being nourished so that I can get a better understanding of what helps them feel safe, and we can build off of that. We need to start there as opposed to trying to start, okay, what do we want mealtime to look like? And then let's take steps backward. We might never get there. We might never get to neurotypical mealtime that we see on television. It might always be not at the table. This child might always want to eat by themselves. Um, and that's okay. But like, let's start there first and work our way in another direction. And what my goal always is first to help that child feel safer and help that caregiver feel less stressed, because that's number one. And that's, we know, is going to set, families up for the most success, because caregiver anxiety, caregiver urgency is what causes the most anxiety for children. And so if you can help that first, like that's the most important thing. Like that feeding matters, pediatric feeding disorder, that psychosocial domain, if that's still causing stress, they still have a pediatric feeding disorder. And so that, as long as the medical stuff, we're working on that, that's the domain that like I really, really focus on first, because that can have a ton of impact on the entire family. I mean, feedings, and we can't forget that either. The entire family is impacted by mealtime, and it happens over and over and over. And so, but you have to be willing to have those conversations with caregivers and be open and honest. And also, I love when you said you introduced this food to this child, it was too much, and you talked to mom and you vulnerably and authentically said, I think this was too much. Let's take a step back, as opposed to not being comfortable enough to say, oop, I pushed them a little too far. And that in and of itself can help a caregiver feel more comfortable. You in a session acknowledging, oop, I went a little too far out of their zone of proximal development. Let's bring it back. Shows vulnerability on you as a clinician, and then can help that caregiver feel safer to say, you know what, I know you asked me to try this at home and it just like really didn't work, or I just like really couldn't do it. It really opens the door more for that also.
Yeah. And the other, as you were talking, Erin, one of the things, and maybe this will lead into like my other case study. One of the things you're saying is asking the caregivers, what does mealtime look like? And I have a parent who is so like, she knows exactly what mealtime looks like for her son. She knows exactly the way he loves to learn about food. We joke that he's going to be like the next YouTube star of cooking, because he loves watching how food is made from start to finish in the kitchen. He absolutely loves it. He wants to be a part of mealtime. He wants everything cooked fresh. And so that was really helpful for me to know, because I had some ideas of, okay, how can I introduce this in my therapy sessions? And that has been so helpful. So we're still working on it. But again, we started off of your preferred snack is a safe food. That took him a long time to honestly feel comfortable to even eat his preferred snack. Like his lunchbox was always there. Mom always packed it, but it took almost like a month for him to want to even just eat it. So
Yeah.
that's
And
like,
that's a lot of information, right? Like that's a lot of information of like, okay, I don't take that as, oh, I'm failing as a therapist. I take that as, ooh, this child has a lot of suit of armor that they have to protect themselves. And I have to work even harder and be even more cautious, not push harder.
yes, yes. And I love that you said that, because we started with, and I know him like specifically, he loves like crunchy solids. He loves crunchy snacks. And so what did I introduce? I think we were doing like a Thanksgiving cookie craft. He loved it so much. And he started to, eat some of the Oreos. And when I first brought that out, I should rewind. What I did was I actually showed him the recipe like at the end of the therapy session, so that he could anticipate what was going to happen the next week. And then so the next week came, we brought out the same recipe and I showed it to him on a video so that he could very clearly see, like, these are the steps that we're going to be taking to make these Thanksgiving cookies. And he saw the ingredients and he was like, I could see that he felt safe. That relationship was there, because he was looking back and forth with me of, okay, we have to get the Oreos out. We have to get the candy corn. We have to get the chocolate chips. And this is a client who is a part-time AAC user. So he's verbal, but using AAC to really supplement his speech right now, because he really, I think there's a motor planning challenge where he's really only able to clearly say maybe like 2 to 3 words at a time. He is starting to say a little bit more, but we have that there as a supplement. And it's so interesting. He'll watch me press the buttons on the AAC, whether it's for cookie or candy corn. And then he wants to, then he is not necessarily activating the AAC, but he's visually seeing that language, input that I'm offering. But then he's also going back to the recipe and he's following all those things. And what I love about this is that he's a kiddo who I think has just an extensive history of being heavily prompted. And so that initiation of language is really challenging. And so when I incorporate the AAC into this feeding task, so much more initiation is happening, even if it's just those 1 or 2 words that he's saying. But I remember him saying like, candy corn, chocolate chips, help me please. So he's like saying all these things on his own because of that safety and that relationship that we've built. And I don't even think I ever thought about it in that way, where for him specifically, it works that I show him the recipe beforehand, we watch a video, and then we do the feeding task. But then I actually did that for another week because I learned that if I do something too fast with him, he's going to be like, oh no, like this isn't good, or this doesn't feel safe. And so the second time that I brought it out the week after, he was so excited, he felt more confident, and he started to use some new language I haven't heard him use. I think he said, good Oreo, which like he had, like his communication functions are pretty limited right now to primarily requesting. And so I love that he was saying that. He said, good Oreo. I think he said, that's yummy for the first time with me, which was so cool.
Huge.
Yeah, so huge. And so I like, that's what our therapy is focusing on, right? Language and feeding. I want him to be able to communicate more about his mealtime experience. I want him to tell me if it's yummy or yucky. He can say yucky too, which is good. Like that's a way that he's advocating or protesting for himself. But like that is what works for him. And what I do with him, I don't do with some of my other kids, and that's okay. But that's what I learned from your course too. Like there is no one size fit all. And I think that we as therapists know this for a lot of other areas in speech therapy.
Yeah.
And I think sometimes we can forget about that in feeding. I mean, I'm not an expert in feeding by any means, but just as I'm learning more, and when I was learning, I just thought that we had to kind of work through this hierarchy of we do this, this, and this. And like so many of my kids didn't like it, but I just didn't know what to do. So it like this particular client I've been working with, he's been so, and even though he's not necessarily doing these recipes at home, I've been doing a lot of caregiver education. And, 1 week mom will come in, oh, he hasn't been eating pasta in years, and he just started eating pasta again. Or he's really interested in this, so, maybe I'll try cooking this again. So that is so important. Like what you said, just because they're taking a certain amount of time to warm up doesn't mean that you're a bad therapist. It's giving you information. And to give a really good example, I brought in, because again, I know he liked videos. I know he likes to be involved in the cooking process too. So I was like, okay, this is such a great idea. I'm going to bring in like a safe knife and things to have him cut some vegetables because mom shared he likes to cut strawberries. And I said, okay, this is great. But I didn't introduce it in a way that was safe for him. I didn't give him a notice the week before. I didn't give him any kind of video. Like I could very visibly see he was not comfortable. And he was like, no, thank you. And so I was like, okay, that was too much. And so now I know how he learns about food. And now I know what I need to be doing with him moving forward.
Yeah, that's beautiful. I love all of that. And it's you saying too, like all of this is information. Like Kim Barthel, my favorite OT, always says, if it's not intervention, it's assessment. Like if I do something and it doesn't go the way I want it to go, which happens all the time with kids, then it gives you more information about who they are and what works for them. And also, I don't love when I go to work and they told me I was going to do one thing and they make me do something else that's really hard. Like that's really overwhelming for me, and I can say that. So we forget so many things about just like kids are human, and like we have to start to put ourselves in their position a little bit more. But um, talking about, even in the way you're talking about assessing this child, there's a lot of so many factors that go into it, like thinking about, okay, motor planning is something that may be challenging for this child. So the video is really helpful for him to know the motor plan that he's going to be expected to do. It gives him more information. And then when I have this routine, that praxis, or like I know how I'm going to learn about something, that can be really, really helpful. And DIR floor time will ever be ingrained in everything that I do. And they talk so much about individual differences, and that's the term that they use for like our assessment of a child and who they are, and that involves their motor planning, their language, their trauma, their family, their sensory system, all of these things. And the way that floor time talks about it is that it's not expanding your scope of practice, it's expanding your scope of understanding. So I need to understand more about this child to be able to support them. I'm not in feeding therapy necessarily focusing on their motor planning, but what I do may support that and it may help. Him being able to say good Oreo, that's because that was in a really meaningful experience, and kids can do really hard things when it's more meaningful. Like if I'm doing, adults can do more complex things when it's more meaningful. Like I would, I'd rather write a book about something I care about. You couldn't get me to write a book about something I don't care about. Like that makes sense. And two, we don't have time in this episode, but I probably will bring Amy back to do an episode even more about like goal writing too, because that's the question I get is like, okay, what are the goals that you write? And Amy has a great neurodiversity affirming goal bank. I have a neurodiversity affirming goal course because um it is all in how you write your goals, and you can think really outside the box. And so for that caregiver coming back to your session saying, oh, I recognize this within my child, and so I thought that this would be a good thing to introduce. That's huge progress on the role of that caregiver. And that might be a goal I write where like caregiver can acknowledge or determine best next food to introduce based on child's preferences and like curiosity cues. Like and then you can write on like that caregiver acknowledge that this was how they liked learning about this food. Okay, well, let's try this. And then if maybe they're way off base, you can write in that goal of how you coach caregiver on maybe we can try this. And so that's a big shift that can happen too. And I think the other thing in feeding therapy is like we're evidence-based is amazing, right? Like evidence-based. I love speech therapists. I really, really do. But speech therapists get a little stuck on speech therapy research. And I've worked a lot of places where, we do a lit review and we can only look at the speech journals. There's so much research in so many other areas that completely apply to what we're doing. Neurobiology is a real thing, and a lot of what I do is based literally off of the brain. But people will be like, where's your research study on it? It's the brain. It's also psychology has been studying this for years. And so don't feel like you have to, yes, we need evidence. Yes, we need understanding for what we're doing. But also ethics of like helping a child be who they authentically are is evidence in and of itself too. And we should be focusing more on mental health and what that means for a child. So I just say that because a lot of people do ask, and I think have a hard time sometimes with like how with the holistic nature of like what we're talking about, but it is really challenging. And that's okay. You just have to be open to like being wrong. And you have to be open to like throwing out kind of a crazy idea. And I'll say to caregivers, this may sound weird, but how would you feel if we did this? Or this may sound kind of crazy, but what do you think would happen if we did this? And so being more open is really, really important. And but not, for the faint of heart, I would say.
Yeah, absolutely. I totally agree with all of that. All of that. I think that it's important that we recognize just it's what you said when we started. We kids don't fit in one box, and every child is so, so different. And we really need to look at all of the pieces of the puzzle. Just because we know one thing about a child, that's one thing that we know. We need to
Hmm.
really look at it holistically and everything that is connected to that child.
Hmm. Yeah, and I think if people are curious, like, okay, but I really don't even know where to start. Like, I don't e- I okay, this is great, but I think biggest things too are like, just try, like you said, just try to see what happens when their favorite food is around you first. Like, see what happens, get information there. You maybe eat with that. Like, see what happens when you bring out your snack. Just like you eat something, see what happens. And then like step back a little bit, like, and tell caregivers, maybe like step back a little bit, because you've been trying, like a lot of caregivers have been trying to control the narrative for so long, understandably so. Like, where does their body want to go? Like, what are they gravitating towards? And maybe just like, I don't mean give in, because I know caregivers, like, I think give them, they'll say, oh, I gave in to my child. And like, you just responded to their communication. Like, you weren't being a bad parent, but like, give in a little bit more, like, see why they're wanting something, give into their ideas, kind of like let go of some of that need to have constant control, and they can guide us a little bit more. Like, what would happen if you just let them pick what they wanted to eat? Or like, sometimes it's too much and we have, you can't have too many foods in front of them, but like, give in a little bit more. um because that gives you more information. We forget how much we're controlling on a daily basis, and so if I allow myself to just let them have more ideas, that can be helpful. And with AAC, Amy and I talk about this all the time: put more food on their AAC device. If you only have the foods they've ever tried and there's no new foods on there, how are they going to ask for it?
Yeah. Yeah. How are they going to know that they have more choices? Yeah. And maybe it's not even giving in. It's just say yes and see what happens,
Yes.
right?
Yes.
Saying yes to more of those things because and I know my daughter is one, but that very much applies to your kids, whether they're neurotypical or neurodivergent. Like saying yes to more things really can just give you a lot of information. And even just going back to what you said, Erin, not placing certain food items at this like higher value. And sometimes I get nervous telling people this because, people do like to judge, but sometimes I just don't have the capacity. And sometimes my breakfast is like a piece of cake because that's what I've got. And my daughter's going to have some eggs and cake for breakfast with me. And because I say yes so much to these desserts, like she doesn't care if she has a piece of dessert. The other day, I gave her a cookie because I needed to warm up her soup, and she like threw the cookie on her plate and was like, like I want that pho that you're warming up for
She
me right
loves it. I
now.
love how much she loves soup.
She loves soup, but say yes and like just see what happens.
Yeah. Um, I'm trying to think, if I was going to ask what would be like your number one advice to like a new therapist who's like, okay, I really want to start feeding therapy, but I'm nervous. Like, what advice do you have for them?
Well, I would probably say go learn from Erin as my number one advice.
This is not
But
an advertisement for my
this
course,
is
but
not an
Amy so would.
advertisement. I promise. I promise it's not. And like if and I'll give you two answers. So if you're a therapist who is like me, who's had some feeding experience and you have that foundational knowledge of, the milestones or motor development, and understand like the importance of, the medical diagnoses and things like that, I would truly say take the pressure off of yourself and just go in there, not trying to get your client to do anything with you and just see what they show you and build that relationship. Like,
Yeah.
and I don't like to tell people what to do, but truly starting off with something so simple of have them watch you eat, have them bring their preferred snack, and don't even think about how are you going to get them to try to do something new.
Mm.
Like that's what
They
I would
can
tell.
tell.
Yes, they can. Oh, they know. They like always watch me. And I'm like, okay, I promise I'm not doing anything because they think, and rightfully so, they think like, well, what did you do to my favorite
Yes.
snack in the world? And so that would be my advice to people who have some of that background. And if you're truly, truly new and you don't know like where to start, I truthfully loved Erin's course that I had taken with her. It was like 8 or 10 hours, I can't remember, but I felt like because I did that, one, it gave me just a whole different perspective, but it made me want to do feeding therapy again. Like nothing that I had taken felt right. Nothing that I was doing with my clients felt right. And I could just see it. Like it just wasn't good. And so I honestly just didn't want to do feeding therapy for a really long time. And it was just like icky to me.
Yeah.
And so after having learned about all these things with you, truly, I think it has allowed me to shift my perspective, and it has allowed the caregivers that I work with to feel like really seen and really safe. So those are my two different pieces of advice depending on like where you are, because I also
Yeah.
know like if you know nothing, like where do I start learning? And I
Right.
felt like all of your stuff was like very comprehensive. But
Well, thank you. I love it. And I think I tried to make it because, I've taken a lot of courses. Marsha Klein is also someone I highly recommend following. She's amazing and does amazing work. Noreen Hunani is a registered dietitian who also does wonderful work with autistic kids, if you're looking for that specifically. But I think what I wanted to focus on too was like, um, it's a muscle of like there's a lot of critical thinking involved. And so I also would recommend that you have a mentor because you're going to come across cases and you're going to be like, huh. It's really helpful to have someone to think through things with and to problem solve because you're never going to have all the answers, literally never. I have mentors, I talk to people HIPAA compliantly, but like think through things because, and from a Floortime perspective, which I will hope be a DIR expert at this point, um, there's some of the most brilliant people I've ever met who all sit around together and like talk through cases because every child is so different. We all have our own experiences. And sometimes it's helpful to just have someone to say, have you thought about this? Or like, have you asked this question? Or like, what does this possibly mean? Because I've thought that kids have done something because of something else and I was wrong. And I needed somebody to help me think through that, or I hadn't thought about something. And so a lot of the feeding therapy that we're talking about is constant, like rethinking and coming up with new ideas and being willing to be wrong. And also you can't take things personally. Like children have their own experiences. Caregivers are going to come in having a rough day and like you can't make it about you, like likely has nothing to do with you. You have to be open, you have to be vulnerable. It's really, really hard. It's really exhausting, but it's so wonderful. And so I think and I think in the speech world, I like to believe the majority of us are really, really helpful and really willing to help. And, when you find mentors and reach out to them, like you have to remember that they're coming with all of this knowledge and training that they have. And so, I remember when I first started mentorship, like taking from mentors too, you look at it and you're like, oh my goodness, this is so expensive. But like it's their time is really, really valuable. And you can get so much from those conversations with them, thinking through and asking those questions. And so just remember that like they're bringing all of their experience and their knowledge and their time. And um, that's important. But then and you'll find people that you just connect with. And um, Amy and I mentor each other. So that's really helpful and people are really willing to help. So, don't hesitate to reach out to people and just kind of ask questions. I also highly recommend DIR Floor Time. It's not feeding specifically, but it's just a really, really, really great course certification program to help you just think about kids and help support them. It's intense because you have to film yourself doing therapy. I also recommend that. Film yourself doing therapy. If caregivers are comfortable, ask them to film what mealtime looks like because that can give you a lot of information. We all say like, oh, I'm doing this or oh, I'm doing this. And you watch yourself and you're like, oh. that didn't come across at all how I intended it to. And it's not your fault. It's just like more information. And I watch videos, and in the course I have like I show a video of a child I'm working with where like I'm there with him. We have a great relationship, and I miss a lot of cues. Like I miss a lot of cues and information about what he's giving me. And that's okay, that happens. But then when I watch the video back, I can be like, oh, now I'm noticing all these things, and now I can build off of that. So we can only think so quickly, and videos can be also really, really helpful for that.
Yeah.
I know we're probably over time. So, Amy, I'm definitely going to have you back because I feel like we could literally talk forever. This went by so quickly. I so appreciate you. Um, where can people find you? If they're looking for resources, if they're looking just to connect with you, tell them, give us all the things.
So if you're on Instagram, I'm on Instagram at amyz.theslp. That's how a lot of people seem to connect with me. So you can send me a message, and I might take a little while to get back to you because I'm not the greatest at checking those. But if you also wanted to reach out to me, you could go to my website. It's speechtherapyconnections.com. And between the words, there are hyphens because I guess speech therapy connections without the hyphens was already taken. So you could also reach out to me there and fill out a contact form, and I'll get that via email.
Awesome. Thank you so much, Amy. We'll have you back for sure. I think hopefully we'll see a lot more of her. She's been on a couple other podcasts too, so feel free to search her name. You'll find her. And yeah, we will see y'all soon.
Yeah, thank you for having me.